Welcome everyone to the Arthritis National Research Foundation's Research Spotlight webinar series. I am Amanda Giannino, VP of Development for ANRF, and on behalf of our Board of Directors, Scientific Advisory Board, and staff, I would like to welcome you to the Spotlight on Autoinflammatory Disease. We are excited to have so many of you joining us from all around the world. First, we would like to welcome and recognize and thank each of our corporate partners for supporting our Research Spotlight series. Thank you, Amgen, for being our gold level supporter. And thank you to AbbVie, AstraZeneca, and AOPI for your continued partnership and dedication. It is because of you, our partnership, that we are able to continue to pave the way for new innovations and learnings from our researchers. Thank you. Now, before we get started, there are a couple logistical pieces of information we would like to share. This webinar is being recorded, and we will have it available on our website and YouTube channel in the upcoming weeks. If you do have questions, please type them into the Q&A. If we aren't able to get to your question, please email info@curearthritis.org after the webinar with your question. Now, I am very honored to turn the mic over to our patient moderator and member of the Board of Directors, Stacy Stringer, to tell us her story living with arthritis. Stacy?
Thank you, Amanda. Hi, and welcome to our Research Spotlight series on autoinflammation. My name is Stacy Stringer, and I'll be your moderator today. I also have the unique pleasure of serving on ANRF's Board of Directors as a patient voice, which is a job I take very seriously. Most of our board members' lives have been touched in one way or another by a loved one who has been fighting an autoimmune disease. And I tried my best to help our board understand from a patient's perspective what having one of these debilitating diseases entail. I know one thing that has been my favorite part of this position is having opportunities like this to chat with our researchers and learn more about what they're working on, but also hearing from other patients about their stories. From the onset of my disease, I've been sharing my story with others for educational purposes and to show that not everyone on social media lives a picture-perfect life. I share to connect with others who are going through what I am, hearing new ways of describing symptoms and having those, yes, that, I feel that too moments, to then be able to share it with our caregivers, friends, and family who have no idea what we go through. I'd like to share a little about my journey with both rheumatoid and psoriatic arthritis before I introduce you to our researchers. My symptoms started after a series of stressful events in my personal life my senior year of high school. I was working at a coffee shop, and the pain in my hands was too much, and I kept dropping hot milk all over myself. I was a competitive volleyball player in high school with multiple offers to play in college. And all of that was ripped away in an instant when I was diagnosed with both rheumatoid and psoriatic arthritis my senior year. I gave up my scholarship to stay in state at University of Oregon and stay close to home for support while I navigated this new disease. I'm in a small subset of patients who present in labs and on paper as a rheumatoid patient, but physically present with psoriatic symptoms, something that has been a challenge for my rheumatologist to manage which disease we're fighting. Finding compassionate physicians has been a constant challenge for the past 19 years that I've been battling this disease. After I graduated college, I moved to Seattle to start my professional career, and little did I know my personal health journey would soon collide with my career. The day before my first job working in advocacy relations, I found out I was changing to a new arthritis therapy. The next day at work, I found out I was working with advocates also on that therapy. I got to share real patient stories in marketing and advertising, which was a humbling experience. I lived in Seattle for 10 years and watched my disease progress in many different ways, but ultimately my quality of life was going downhill. Every 2 years, I tried a new therapy, hoping for a better result. At one point, my doctor shared with me that if I felt at least 20% better, that we needed to take that as a win. I wish I would have had someone further along in their journey to talk to me when I was first diagnosed, to tell me to try to give medications as long as possible, because after 10 years, I blew through almost all of my options. Towards 2017, my pain worsened and moved to my back. I was debilitated and could no longer live alone. I moved back to Oregon to receive help from my family. This was at a point a conversation with a family member helped me look outside of the state for a physician that would step outside of the box when it came to my treatment plan. I applied to become a patient at Johns Hopkins in April of 2019. I finally flew across the country to see my new doctor in June of 2020. And when you meet a doctor who is on your side and wants you to live the best quality of life, it feels like a weight has been lifted from your shoulders. I still see a local rheumatologist that manages my day to day, but my physician at Johns Hopkins has helped me fight insurance and help steps outside of normal treatment options and get creative, as I have one more option left to try before I am out of options. That is why getting involved with ANRF has meant so much to me. The researchers, although what they're working on may be years down the line to come to fruition, it is your and my quality of life on the line, and it will directly affect our future. And for that, I am so grateful to be a part of this organization and to have this opportunity. But with that, I'd love to introduce you to our first researcher, Dr. David Beck. Dr. Beck received his MD, PhD at New York University School of Medicine, where he has studied biochemistry and sulfate decisions. He has now joined the faculty at New York University School of Medicine to run a program studying VEXAS syndrome. His work focuses on trying to identify genetic causes of diseases in patients and use laboratory investigation to help provide insight for clinical care. I'll pass it over to you, Dr. Beck.
Thank you so much for having me here. Thank you for the opportunity to talk with you all. And Stacy, thank you for sharing your experience. It's motivating to us researchers to think about how we can improve care going forward. So thank you for sharing. So I'd like to talk to you today about VEXAS syndrome, which is the focus of my clinical and research efforts. So just a few words about my background. I'm a physician scientist. As Stacy mentioned, I worked at NYU as an MD PhD student, and I've trained both in science and in clinical care. So I did internal medicine residency at Columbia, and then clinical genetics at NIH and Johns Hopkins. And so I had the opportunity to do research with Dr. Dan Kastner at the NIH, where in his lab, where he's identified many different genetic causes for rheumatic diseases, inflammatory diseases, and in particular, defined the category of autoinflammatory syndromes. So, and now over the last 2 years, I've taken a faculty position at NYU, where I've tried to integrate these different approaches: the molecular biology, biochemistry, genetics, trying to identify the causes of disease, and clinical care, particularly focused on these autoinflammatory diseases. So what is VEXAS? So VEXAS is an autoinflammatory disease, and these are diseases where there's recurrent inflammation without a clear autoantibody or autoimmune component. It's when the body is basically having fevers or inflammation without any clear cause and pretty much persistently. And we're going to hear about sort of a more common end of it later on today. VEXAS is more on the rare side in terms of autoinflammatory diseases. So patients with VEXAS syndrome have severe inflammatory symptoms, low blood counts, and their disease starts later in life, usually in the 50s and 60s, and primarily presents in men. And what's unique about VEXAS syndrome as compared to other autoinflammatory diseases or rheumatic diseases is that it's caused by mutations in a single gene. The gene is UBA1. And these mutations, these single base changes, errors in the DNA, occur only in the blood. They're restricted to the blood. And patients aren't born with the mutations, they're acquired over their lives. So it's different than germline mutations, germline diseases, in which they're passed down generation to generation. These are mutations that are occurring just in the individual, just in their blood. And why we're excited about understanding UBA1 and VEXAS is because we know the cause of the disease, UBA1, we think we can better understand how to treat it. So what is VEXAS syndrome? So VEXAS is an acronym. It stands for vacuoles, which are often present in the early cells in the bone marrow. So that's where our blood is made. It's these features in the cell, as you can see circled in the bottom right, are vacuoles, these big globs. E stands for E1 enzyme. That's what UBA1 gene encodes for. It's an important enzyme that works in the cell to help protein turnover. UBA1 is on the X chromosome, so that's where the X comes from. A is for autoinflammation, and S is for somatic or acquired mutation. And our hope is with this name that it can help recognize the important signs and symptoms of this disease. So what symptoms come along with VEXAS syndrome? So it affects multiple different organs. So the mutation is present in the white blood cells in our circulating our blood. Those are the immune cells that help fight infections. And it causes symptoms in many different organs. So we can have symptoms in the skin with painful rashes, in the cartilage with pain and swelling of the ear and nose, in the lungs with cough and shortness of breath, inflammation in the joints, and in the blood vessels. I mean, what's important about this disease is many times patients can have symptoms that look like common rheumatic diseases and can even meet criteria for them, but patients will actually present with unique manifestations that are not quite like rheumatoid arthritis or psoriatic arthritis, and they're more in line with this multi-system inflammation. And why that's important is that knowing that the disease is caused by the VEXAS syndrome, the UBA1 mutation, can change care and can change what we monitor in patients. So we think it's important for this to be better recognized in the community. VEXAS syndrome is more common than expected. So even though this was just recognized a few years ago, we now know of hundreds of patients worldwide. And partly this is because some of the rheumatic diseases are challenging to diagnose. So how is VEXAS diagnosed? It's diagnosed through both the symptoms, but primarily through genetic testing. So having the UBA1 mutation. And we've found that it's actually present in 1 in 4,000 men over the age of 50 and 1 in 14,000 individuals overall. So although it's not a common disease, it's a disease that may be affecting people that you know and love, and definitely is present in many hospital systems across America. And we think it's likely present in more than 20,000 Americans, although very few of them are diagnosed given this rate. So what do we do for patients who have VEXAS syndrome? So it's a severe inflammatory disease. It's also sometimes associated with blood cancers or myeloid malignancies. And we know now that the treatment is primarily effective is treating with prednisone or glucocorticoids. And why this is important is, at least for now, many times patients are tapered off of their steroids. I think many people on the call and have experienced this. But we think that keeping patients on prednisone is important because they have ongoing inflammation when they have the VEXAS syndrome mutation. There's some evidence, and this is an ongoing clinical trial at the NIH, that bone marrow transplantation can be helpful for treating this disease. So this is obviously a treatment that comes with significant risks associated with it. But for patients who have very severe disease and who have involvement of the blood counts, this is a consideration. And then we're, along with other groups, working on trying to design a clinical trial that can better treat VEXAS than the current treatments that are out there. So this is something that we're actively working on. So my lab is really interested in understanding why these UBA1 mutations lead to disease, what the connection is between the mutation and disease. We're doing this in a few different ways. So one way that we do this is by broadening our understanding of treatment and natural history of VEXAS in patients. So a lot of what we learn about the disease is through understanding the different clinical manifestations patients can have, the treatment responses they have, and the different markers of inflammation they have. So we're tremendously appreciative of patients who both get their ongoing clinical care or participate in research in our clinic, because it helps us understand this disease and helps us be able to better treat individuals in the future. We also think that model organisms or animal models of disease are really important. So what I mean by that is that we have a mouse model where we can copy the process of VEXAS occurring. So have a UBA1 mutation, watch disease formation occur, and try to reverse the disease. So through these studies, we can analyze why UBA1 causes inflammation, how best to reverse the inflammation, and hopefully use this information to be able to return it back to patients in the form of better treatments in the future. So these are longer term goals that come from our animal model studies, but that will hopefully inform our understanding of disease. So I just want to kind of summarize some of the major things that I've talked about today, is that VEXAS syndrome is a frequently overlooked cause of inflammation and blood problems in patients. So if you're a patient that's experiencing recurrent inflammation, low blood counts, and really aren't responding to the therapies your doctors are prescribing, it's something to consider and something to bring up with your doctor. The diagnosis is made via genetic testing, and many times testing is sort of doesn't change care. But we, sort of in the clinical and research side of VEXAS understanding, we're currently recommending changes in patients' treatment, changes in patients' clinical care in terms of monitoring based on this genetic diagnosis. So we think it's important for making sure we identify patients so we can provide them better treatments. And my lab and really support from the ANRF is focused on improving our understanding and treatment of the disease. So we're just at the beginning of this understanding. We know the mutation causes the disease. We know how to recognize patients who have it, but our goal is to be able to better treat this disease. And we're hoping that understanding how to treat this disease and why UBA1 causes disease may help us understand more broadly autoimmune diseases. Could treatments for UBA1 be useful in other cases? This is also part of our efforts in the lab. And I'm always happy to take emails or calls about questions about the disease. Feel free to email me. I think that sometimes the most challenging part about being a patient with a hard to diagnose disease is not having someone that you can reach out to. So if you have concerns or questions about VEXAS or autoinflammatory diseases, please feel free to email me. And with that, the work that I do is not possible without the participation of patients and families who willingly volunteer to be involved in genetic studies and research studies to understand their diseases. Tremendous collaborations with my postdoctoral mentor, Dan Kastner at the NIH, my lab members who trust working with a new faculty member, and support from foundations like Arthritis National Research Foundation. So thank you so much for listening and tuning in, and I'm happy to take any questions.
Thank you so much, Dr. Beck. That's so interesting. And again, if you are on the webinar and have any questions, please feel free to enter it into the chat. We will try to get to as many questions as possible. But first, I guess my first question that I have for you is, do physicians out there know about VEXAS syndrome? Are they looking for it in their patients, or is it something that us as patients or caregivers should be looking at our blood work and bringing it up to our doctors? How is VEXAS syndrome kind of getting out to the masses?
Yeah, so it's a really good question, and maybe one that, you know, the ANRF is going to be better at solving than I have been. A lot of the research group that has been focused on identifying it, the collaborative group that's worked on it, have been giving talks to physicians, publishing papers, trying to give webinars like this that go directly to patients. But still, I think that there's a lag that happens where recognition takes time. So, you know, we're doing our part, but, you know, there are definitely ways to get, not enough patients are being diagnosed yet. So I think that patients advocating for themselves is important. We know there was recently a Washington Post article about a patient who struggled getting a VEXAS diagnosis. So any means that we can to help expedite the knowledge being spread is important. And we're taking multiple different paths at once.
That's great. I guess my other question would be, if patients do and are diagnosed, is there a way that they can get involved with your study? How can they get involved to assist?
Yeah, so it happens now quite frequently that patients have questions about their diagnosis. Maybe they've been diagnosed at a hospital already because of the recognition of the disease, but there are many questions that their local doctor can't answer. So they can email me and we set up a call and try to answer some of their questions. And depending on what their manifestations are and where they live and these sort of things, we can enroll them in our study or provide clinical care. We've had patients fly in to get clinical care at our VEXAS clinic, and we'd be happy to do that depending on people's needs. But I think, you know, you touched on this a little bit before. I think there's nothing more frustrating than suffering and then having someone say that they don't understand anything about what's going on with you. And so our hope is that for the patients, at least that have this mutation, we do know some things about it, and we want to learn more and more. So that's the efforts of my group and many others too. So
That's
please.
great. And as a patient, I think that's something that I look for in a physician. And so the fact that you're providing that type of care for patients with something like this is so fantastic. So really appreciate the fact that you guys are putting all this research into this. I know you kind of went over it, but I thought it might be just good to one more time kind of just go over, are there any, what the signs and symptoms are for patients to be paying attention to outside of normal autoimmune joint pain and swelling that if they see or feel they should bring up to their doctor?
Yeah, so that's a great point. So um, this is a disease where it can have many different manifestations. So in terms of patients looking out for symptoms, we sometimes find that they have many different types of rashes. So they can have these raised red, painful rashes on their chest and back, even on their scalp. Not all individuals have that, but some do. Inflammation of the ears and nose, so swelling, redness of the ears and nose. Patients will have some of the arthritis that you talked about, but recurrent fevers, blood count abnormalities. So that's not something that patients will feel, but doctors will be looking for. And sort of this, one of the challenging things I think about autoimmune diseases or rheumatic diseases in general is fatigue, and I think just
Big
kind
one.
of being able to better describe and what you used to be able to do and what you're currently able to do is sort of a metric for fatigue, because it's hard for us as physicians to understand what patients are going through, but thinking back at what you're able to do and what you're not able to do now gives us a better understanding of how disease is affecting your life. And it's hard to put a score to that, but we do find fatigue as being one of the big factors that inflammation is going on, causing in patients. And what I'll say is that with VEXAS, there's an ongoing inflammation that makes patients almost feel like they're having an infection all the time. It's like you're walking around with the flu all the time. So how do you describe that feeling? Being achy, being fatigued, being tired. That's in addition to the specific symptoms that I described before. But it's hard to kind of
That's
get hands on that exact symptom.
Oh, for sure. And I know the fatigue factor is huge. I wrote a blog post about how I spent most of my 20s asleep because my disease just worsened so much in those years after my diagnosis. So I know
Yeah.
that's a challenging things for a lot of people to really understand. Are
Yeah.
there any other common co-diagnoses with VEXAS syndrome?
Yeah, so we find that a lot of patients have known autoimmune diseases, so they can meet diagnostic criteria for different vasculitis. So whether it's polyarteritis nodosa, giant cell arteritis, relapsing polychondritis, we've had a few patients who have been diagnosed with lupus or rheumatoid arthritis, and then blood disorders like myelodysplastic syndrome and multiple myeloma. What I want to say is that it's not that a lot of patients who have these diagnoses have the UBA1 mutation. So if you take individuals who have lupus, very, very few are going to have a UBA1 mutation, have VEXAS syndrome. But what it is that a subset of folks who have these common rheumatic diseases don't quite fit the picture, have manifestations that are not responding to treatment, have symptoms that are kind of outside the spectrum of lupus or rheumatoid arthritis. Those are the individuals that we're talking about, kind of the outliers in these more common diagnoses. And that's one thing that's been a little bit surprising about this genetic disease is that usually for genetic monogenic diseases where a single gene causes disease, the disease doesn't look like others. It looks like its own, right? It's something that stands on its own. That's what a familial Mediterranean fever or other periodic fever syndromes. But this kind of can look like a common rheumatic disease. And I think that's been a little bit the barrier in recognition in clinics. Why are we looking for a genetic cause if someone already has a diagnosis of relapsing polychondritis? Well, it doesn't quite fit. They're not responding to treatment, and they have too many other, clinical manifestations. So part of it is thinking about it is that it's not an undiagnosed patient. It might just be a patient who's diagnosed, but the diagnosis doesn't fit and the treatment's not working well.
Yeah, definitely that. And I think getting it out there so patients can just know about VEXAS syndrome and realize this might be something we need to research a little bit more and poke my doctor to check into as well.
Yeah. As
Um,
you know, you're your own best advocate in many
oh,
cases,
for
right?
sure. For sure. And so are caregivers. I know I have to ask my family sometimes when I'm flaring, I need that extra assistant from a caregiver and family and friends to really kind of fight for me at doctor's offices. I'm in my 30s and I still have to take my mom to the emergency room with me to get proper care, which is frustrating.
Yeah.
So I'd love to know though, what inspired you to research VEXAS syndrome? Is there something that personal or what caught your eye about this?
Well, I mean, it wasn't VEXAS syndrome in particular. It's still, I'm broadly interested in trying to figure out what causes diseases. So I use genetics as a way to find the cause of diseases. And this is one of the diseases that we found the genetic cause for. Why I'm interested in genetics is because genetics is the beginning. Once you know
Yeah,
how the process started, and it's only a subset of diseases have a genetic cause, but in the process, the subset that have a specific genetic cause, we know what started it. We know where the fire began. So that's a very powerful way to think about how to stop it.
for sure.
So, and what we know also from genetic diseases, even when we know these targets, the causes of diseases, even in patients that don't have the genetic mutation, targeting that spot can be helpful in others. So those rare disease examples can be more broadly applicable across more individuals. So that's sort of the motivation.
That's great. What challenges do you feel like researchers are currently facing in advancing our understanding of these disease states?
Well, I think you nailed it right off the bat. Recognition by clinicians getting the word out to be able to find patients and help them diagnose. Um, we're limited in what we know based on who gets tested about VEXA syndrome or other diseases. So, sort of thinking about when to test and how to test individuals is one barrier. And sort of another thing that you touch on is just sort of advancing our understanding of diseases. It takes a long time to sort of get new ideas into common clinical practice. And so that's a little bit of a frustration or a challenge in the job, is to be able to take rheumatologists who've been on the job for a long time and bring VEXAS into the common language that they use in their practice. And part of that just takes time.
Definitely. I know it was always a challenge for me with rheumatologists because there's not that many younger rheumatologists. A lot of them are older and they're kind of stuck in their ways sometimes. So it's always nice to hear some younger physicians that are staying on top of new research and paying attention to what's going on in the field. But what
Personally,
advice would you? Oh, go ahead.
oh, I'm just going to say that sometimes in fields of medicine in which there's so many new medications that come out in rheumatology, it's exciting to see all the new options that appear. But sometimes there's a disconnect between what happens clinically and what happens in the research lab. So in some ways, that's an opportunity to help advance medicine even more, right? Is to be able to find the new ways to think about disease, because we've been thinking about them the same way for for decades, right? Are there new ways to classify patients to treat them? So our hope is that genetics will be a way to help classify patients to better treat them.
Definitely. And I think it's really interesting too. And I've moderated a couple different webinars with ANRF. And I think bringing patients and researchers together is also a really great bridge to gap to bring the patients in kind of more at the beginning level and know more about their disease state and what's coming down the pipeline and what's being researched. I know when I first got involved with ANRF, seeing all the different research actually gave me so much hope. As I mentioned, I'm on one of my last therapies before I don't have any options left. So seeing all the work that all the scholars are doing is so exciting for me and for my future and my friends that I know that also have autoimmune diseases. So I think it's such a great organization to be a part of, and I've really enjoyed getting to know the researchers at the symposium and through webinars and whatnot. So I
I would
also
just
just
say,
wanted, yeah,
oh, sorry. I would just say that my research isn't possible without patient participation, to find the genetic cause of disease, to understand them. So, I'm glad you're inspired by it, but the partnership between patients and researchers, at least for some areas of research, is so intertwined, right? You're looking for hope and we're looking for clues how to help,
yeah,
right? and thinking about that partnership and that's how I think about it, as a partnership, so helping to work together to find clues how to better treat patients, because we're not going to do it in isolation. We have to understand what's going on with you, to be able to find those clues.
Definitely. And that's one thing when I'm at my doctor's offices, I've been at two different clinics that have had research included. And so I've done my best to assist and participate in all of the research that I can with my physician. So I definitely encourage other patients and caregivers to ask your physicians if there is research happening that if you'd like to be a part of, because it's only going to help advance what's happening in the research field. So I guess my last question for you is, what advice would you give to any other new career scientists looking to be accepted to receive a grant and be a part of ANRF?
Oh, I think, just sort of starting from an important question, thinking about unique or new ways to sort of answer that question that will be applicable to lots of patients who suffer from diseases. And I think that the foundation, I'm new to it, it's my first year, but seems really broadly focused on many different areas to help with arthritis. There's many different types, so just sort of having a creative or a new way to look at diseases that are affecting millions of individuals. We're going to hear about that now, gout, but I think that they're interested in so many different areas that there's a lot of opportunity.
Definitely. Well, thank you so much for your time and insight, Dr.
Thank
Beck.
you.
I know I learned so much from you in your presentation and our conversation, and I'm sure your patients are so lucky to have you in their corner.
Thank you.
So next, I'd like to introduce you to Dr. Megan Leask. Dr. Leask specializes in genetics of gout and other complex diseases, genomics, and bioinformatics. She completed her undergraduate, pre-doctoral, and postdoctoral training at the University of Otago in New Zealand and moved to the United States in 2021. She is currently an instructor in the Division of Clinical Immunology and Rheumatology at the University of Alabama at Birmingham, developing independent research portfolio. She's joining UBA, her research, and has been focused on translating non-coding associations identified in an extremely large genome-wide associative study in gout. Take it away, Dr. Leask.
Oh, thank you very much for that. And yeah, I guess today I'm also going to be talking about a disease that we know is caused by genetics. It's quite different than VEXAS. We think that gout is caused by many different spots within the genome that are changed in different individuals. So not just one mutation, but hundreds of different genetic differences between people. And so today I'm going to be talking to you about my work, but it's also being carried out by many of my colleagues. And we've been working on this very large study that has been trying to identify all these genes that are important for gout. So what is gout? So for starters, it's actually the most common form of inflammatory arthritis worldwide. It affects more than 6 times as many people that have rheumatoid arthritis, and it affects males a lot more than females, and the prevalence of gout increases with age. This form of arthritis occurs periodically. So when it does, it's called a gout flare. And this is something that happens when the immune system recognizes and responds to these crystals that are deposited into the joints. And for this to actually occur in people, people must have high levels of a substance in their blood called urate. And because of this, most people with gout will receive treatments that lower their urate, and these are called urate lowering therapies. And some of these are allopurinol or febuxostat. But people with gout will also take drugs that treat the immune reaction of the gout flare. So they will use things like NSAIDs, which reduce inflammation. And so even though these urate lowering therapies are excellent therapies on paper, the majority of people's gout actually remains poorly managed. And it's due to a number of different reasons, including one, just not taking urate lowering therapy, but also there's underdosing of these drugs, and there's also resistance to these drugs. So because the prevalence is so high, about 3% of the population is affected by gout. And because these drugs that we currently have aren't so great, there really is this clinical need to identify additional therapies for the treatment of gout. And one way we can do this, one way we can find new drugs, is to understand and identify genes that are involved in both steps of gout, so hyperuricemia and the immune response. Just trying to. So the first prerequisite of gout is hyperuricemia, or high serum urate. And there are two organs in the body that sort of deal with urate, and they are the liver and the kidney. And the majority of the urate is produced and excreted into the blood by the liver. And this occurs after we digest molecules called purines. And these purines come from our diet. These purines are converted to urate by multiple enzymes. And it's this step where those urate lowering therapies like allopurinol and febuxostat function. They inhibit the enzymes that are important for producing urate. But like I said before, serum urate or high serum urate is not the only thing that's required for you to develop gout. There is that second prerequisite, and that's the formation of these crystals in your joints. And so when you have high serum urate, you are more likely to have these crystals in your joints. However, we're beginning to learn that urate crystals can actually be found in many different places in the body, including the kidney and in our blood vessels. So it's quite important to start learning how these crystals are deposited into these different tissues. Importantly, it's these crystals that give rise to this second prerequisite, which is that innate immune response and that inflammatory reaction to these crystals. So if you've ever twisted your ankle, you'll know that you get a lot of inflammation, which is the result of all these immune cells rushing in to first protect the injury and then to begin healing it. And depending on the injury and the amount of inflammation, this can lead to quite a lot of swelling and extreme pain and heat at the injury site. And so the same actually goes for gout. The immune cells, they're rushing in to attack and eat up these crystals, and this results in swelling and pain, which is characteristic of that gout flare. However, at the moment, we currently know very little about the genes that are underpinning this very complicated immune response. So I guess if there's anything I really want you guys to take from my talk today, I want you to know that gout is a disease that's contributed to heavily by genetics. And this is an extremely important point because for a very long time, gout sufferers have received a lot of stigma because people have thought that it's a disease that's caused by things like heavy drinking, overeating, and poor lifestyle choices. But we now know that there are these genetic risk factors for the disease, and that diet and lifestyle are really not big contributors to gout. And one thing that points to genetics as a cause is the vast differences that we see between people of different population groups. So, for example, people of the Pacific Islands, they actually have inherently higher levels of serum urate. So they have genetically encoded high levels of serum urate than other population groups. And this actually holds true if they are living in westernized countries like Australia, New Zealand, and the US, or in the Pacific Islands. So their serum urate levels don't change between the Pacific Islands and westernized countries. And so people have tried to explain the differences in the prevalence of gout between the Pacific Island people and other groups due to Western or exposure to the Western diet. But we know that this isn't true. And we also know that the skeletal remains of people from the Pacific, identified or found almost 800 years ago, had this evidence of these bony erosions, which are evidence of gout. And so when we look back at the skeletal remains, we can see that these people had gout a long time before the westernized diet was even introduced to their populations. So this really suggests that this disease is genetic, and it's got nothing to do with lifestyle choices, and it's more to do with genetics. So up until now, the vast majority of genetic studies that have been carried out studying gout have actually been looking at how serum urate might be controlled by genes. And so we haven't really learned much about the immune response and how that might be controlled by genes. And this is mainly because it's actually extremely difficult to untangle these two phenotypes, I guess. One, serum urate is a prerequisite for gout, and two, gout sufferers have high serum urate. So it's been really difficult to find the genes that might be underlying the immune response. Despite all this, there have been a couple of studies in the last 10 years that have looked and found genes that are responsible for serum urate. So there was one study in 2012, which was working with 140,000 participants, and they identified 18 genes. And then there was a larger study a couple of years later, which was studying people with high serum urate. There was about 330,000 people in that study, and they identified 183 different genes. And so from these studies, we found that most of these genes that are involved in controlling high urate levels are these kidney transporters of urate. But we didn't find anything about the inflammatory or the immune genes. And so I really wanted to take you on a wee journey of how we've begun to do that. And it really is about 15 years worth of work, because it is, that's how long it takes to get your ducks all in a row for doing this type of genetic study. So at the beginning of this particular project, lots of rheumatologists came together and were involved in the recruitment of patients with gout, so that we could recruit them into this study. And so the very beginning of this project, there was the European Crystal Network, and then that sort of exploded into the Euro Gout Consortium, and they were involved in contributing roughly 7,000 participants with gout into this study. But we needed a lot more than 7,000 participants. And so the study really transformed when that company 23andMe got involved. And so 23andMe is one of those genetic testing companies where you can send your DNA away and find out about your genetics and your ancestry. And millions upon millions of people have actually done this now. And when they do this, 23andMe asks a bunch of questions about your health, including one of these questions which asks, do you have gout? So now we have all this data on quite a few people about whether or not they have gout or not. And so when we included these participants in our study, we were able to increase the number to 2.6 million people, with 120,000 of these people having gout. And so when we did this study, we did a lot of fancy statistics, which meant that we could link the different genes from each individual in our study to the risk of gout. And so when we did this, we were able to find 560 different genes in the genome. So that's about, there's about 25,000 genes in the genome. So 560 different genes that we could link to risk of gout. And so it's been my job in the last wee while to filter through these genes to find out which ones could be really important for the immune response. So I've begun to test how these genes might work, and started doing this using an experiment that uses immune cells that we have isolated from people's blood samples. So I was going to quickly take you through how I do this. The first thing we do is we actually just get some willing participants to donate their blood. And most of the time, this is people from our lab. And this just ensures that the samples are really fresh and reliable, but it also means that we're not wasting patient samples with gout. And we just want to make sure that the assays or the experiment is working using easy to access blood samples rather than wasting blood samples from patients. To get the immune cells out of the blood, we put the blood into a specialized tube that has some thick liquid in it. And once the blood has been added, we put the tubes into a centrifuge and we spin the tubes around really fast. And what that does is separate out all the different types of cells that are within our blood. The big heavy cells, like our red blood cells, go right to the bottom, and the lighter ones, which include those immune cells that we're really interested in, stay at the top, and so we can use those. And once we isolate those immune cells, we can then put them into these wells of these plastic plates and use a specialized liquid media that has all the nutrients that is required to start growing these cells. And then the final thing that we actually do is we expose these cells to the exact same crystals that cause gout. And this produces an inflammatory signal that we can start to measure. So the next step in this experiment is to test the genes that we've found. And to do this, we use special inhibitors of these genes, and then we look for differences between those that have been treated with the inhibitor for a particular gene and those that are controls, or those that haven't been treated with an inhibitor. So right now I'm going through about 10 different genes that we think would make good drug targets, and looking to see if these particular genes increase or decrease the inflammatory reaction of these cells. So hopefully my talk today gave you some insight into the type of work that I'm doing and the type of work I'm doing to come up with better drug treatments for gout. The work couldn't have been done without the help of everyone in both the Merriman lab and the Leask lab, and the funding that we received to do this. And so I'd just like to thank everyone for listening and invite any questions that you might have. Thank you.
Thank you so much, Dr. Leask. This is so interesting. I have some family friends that have gout, so I know that more research definitely needs to be done, and it's really interesting to see all the work that you guys are doing. I'll dive right in with some questions, but again, if anyone in the webinar has any questions that they would like to ask Dr. Leask, please enter it in the chat and it will be filtered through. But I guess I'll start with an easy, just two-part question. What made you want to become a researcher, and what inspired you to research gout?
Oh, that's 20 years ago when probably even longer. I would have been about, I think I would have been about 7 or 8 when I really started getting fascinated with like human biology, the human body. And I'll be honest, I probably did want to be a medical doctor, and perhaps I didn't study hard enough when I was a teenager. But I fell into genetics in my undergraduate studies. And then I was just fortunate enough to have a really great mentor after I finished my genetics PhD, who was pretty much the world-leading researcher in the genetics of gout. And this was back in New Zealand. And in New Zealand, we do see a lot of gout because we have a large Pacific population, and we know that they experience a lot of gout because they have this increased genetic risk for gout. And so that's the reason why I'm studying gout today. Yeah.
That's fantastic. Are there any ways that patients can continue to contribute to your research? Can they sign up for 23andMe, or are you guys past that point of gathering data?
We're probably past the point of gathering genetic data. I think we've done a large enough study now where we've got a ton of genes to be following up. 560 different genes is so many to start working on. but we still have patients contributing to our work by providing blood samples, their immune cells, so that we can do the assays that I took you through today. But I guess patients would have to probably be in Alabama, where I'm working on this at the moment, because the samples do need to be fresh. But if anyone was wanting to contribute to our study, I mean, reaching out and just asking if it was feasible, we're always keen to find participants that might be affected by gout. Yeah.
Oh, definitely. Well, we'll make sure that we have your information available too. So if there are any patients or caregivers that are interested in participating, they can get in contact with you.
Yeah, sure thing.
Are there any new diagnostic methods or tools that could help improve early detection in gout?
No, not that it springs to mind, but I guess that's what we're keen on developing here as well. So, I took you through maybe our assays, which might be trying to find drug targets, but also we can, come up with somebody's genetic risk for gout. And so we could start, we could test people at a young age to see whether or not they are more likely to develop gout than other people. And so I can see this becoming quite commonplace in medicine in the next 5 to 10 years, not just for gout, for all these conditions that are contributed to by genetics. And so perhaps if we could identify people before they developed gout, we could put them onto therapies that meant that they never even got there in the first place. They might have high serum urate, so we could lower it before they even had their first gout flare. But this thing, precision medicine, which will be contributed to by genetics, that's sort of where I hope that this research will go, and that we will be able to start treating people much better based on their individual genetics.
Yeah, I find that so interesting. And that actually kind of jumped into my next question on future trends in the field. And I think being able to really jump in at the beginning of a patient's life and see what could be coming down the line for them is going to change a lot of people's lives in the future. And I'm excited for that to come out and to see what all the researchers have coming down the pipeline that could help out patients in the future.
Yeah, and I guess this approach of like looking into people's genetics could actually decrease the inequities that we already see in patient care. So with in New Zealand, we see a lot of Maori and Pacific people that are affected by a lot more conditions that are easily treatable. And in America, African American people, they are receive inequitable care. And I think that genetics has the power to reduce this gap.
Definitely. And so are there any challenges that researchers are currently facing in advancing our understanding of gout?
Yes, we know so much about how serum urate is controlled. We know it's working in the kidney. We know a lot about the genes, but we don't know very much about that immune reaction. Some gout sufferers will get one flare every 3 years, and other gout sufferers will get a flare every month. And there's nothing to pinpoint why that is at the moment. So we're really keen on figuring out those complexities, and we think that it's more to do with the immune response than those genes that are involved in high serum urate.
That's awesome that there's so much more being done with gout, because I know it has been a disease state that needs a little bit more light shown on it. So
yeah, it's not a very fashionable disease.
No, not at all. So I know there's so many people that suffer from it. So it's so great to see some of our scholars that are really researching gout. So thank you for all the work that you've done in this disease state. But I'd like to ask you, in your career, tell us the #1 impact of receiving a grant from ANRF has done to shape your lab and your research.
Well, the ANRF grant actually meant that I was able to employ somebody to help me do this. We, as a researcher, we do sometimes get bogged down with quite a lot of the admin, trying to write papers, trying to write more grants to get more money. And really, we need people to help us do this work. And I have this really enthusiastic young guy working on this project, and it means that I can actually start to get stuff done. And so I'm really excited about that. Yeah.
Oh, that's fantastic. I know it's nice to have someone in there too to bounce ideas off of and work through things. So my last question would be, is there just anything you'd like to add or share or say to patients, caregivers, other scientists or donors that are on the webinar today before we wrap up?
That's a very open-ended question. We're trying our best, and we're really working towards coming up with new therapies for gout. And I guess if you did have any questions about gout and serum urate, then feel free to reach out to me, and I'll try my best to either answer it or put you onto somebody that can answer it. Because as a disclosure, I'm not a rheumatologist. I am trained in molecular biology, but I am hanging around in a department right now that has some of the world leading rheumatologists in it. So I can surely put people onto the right place.
That's fantastic. Thank you so much, Dr. Leask, for sharing your research with us and taking some time to chat with me regarding gout. I've learned so much, and I'm so excited to see where your research takes you in the future.
Thank you.
Again, I'd like to thank Dr. Beck and Dr. Leask for their time and their presentation today. I think I can speak from all of us patients to tell you both that what you're doing directly affects each of us suffering from an autoimmune disease. The research that you're doing today will directly affect our quality of life in the future. So thank you so much. And at this time, I'll pass it back over to Amanda.
Thank you so much. And as we wrap up, I do want to say thank you to our amazing moderator, Stacy. Great job. Thank you. We are so appreciate you being here and sharing your story. Also, to our wonderful researchers for sharing your innovative work towards understanding osteoarthritis. You can now see firsthand the impact ANRF has in supporting these incredible individuals in their personal quest to find a cure. I would like to once again thank our partners, Amgen, AbbVie, AstraZeneca, and AOPI. Your support of these webinars. Thank you. And lastly, thank you to everyone who joined us for this event and for all of your wonderful questions. Thank you all again for coming. And please remember to follow us on social media, as we will all stay connected. Thank you.